welcome or welcome back to another session of A Day with your fertility specialist. Thank you for joining us today. We do appreciate you every time you're on here, every like, every comment, every click, and every share. On that note, you might want to share this with someone that would find this topic quite helpful or even just interesting. We're talking about endometriosis and fertility. So, how these two things affect each other or how one affects the other. Um, you know, I've heard about endometriosis quite a lot. I myself, at some point, thought I had it, but there's a lot more that goes into it. And today, we're going to learn about that. We have Dr. Ken with us this afternoon. Hi, Elsa. Welcome on the set once again. Thank you for joining us. As
Thanks.
always, it's always a pleasure to have Dr. Ken on set. If you know, you know. Uh, in case you're joining us for the first time, Dr. Ken is a consultant gynecologist and an IVF specialist. So once again, we have two of these very interesting topics, both a gynecological issue and a fertility issue. And who better to tell us on these things than Dr. Ken? So, sir, like I said, I've heard about endometriosis, but for someone out there that might not have heard about it, or they could have heard about it and they don't really know exactly what it is, could you help us out a little bit? What exactly is endometriosis?
Thanks. Good to be on set with you.
Yes, sir. Thank you.
And we hope to make this topic a little fun
Yeah.
and more enlightening to the population. Sometimes ago, I watched a colleague of mine, I call a senior colleague,
Okay.
who is a specialist in endocrinology, in endometriosis, and walk around streets of some countries and asking people whether they've heard the word
Oh,
endometriosis.
okay.
And so many people haven't heard about it.
Mm-hmm.
Yeah. And then a lot of people liking the period pain, the menstrual pain to
Yeah.
endometriosis, and it makes it look like once a lady has pain during menses, she has endometriosis,
Yeah, that's what I used to think as well.
So that's actually not correct. It's actually not correct because there are a lot of causes of period pain
Okay.
aside endometriosis.
Mm.
Fibroid could cause period pain.
Yeah.
Adenomyosis, which is like endometriosis,
But not quite.
occurring in different locations, could cause painful periods. If you have some other growths on the lining of the womb that gives you heavy bleeding, like
Yeah. Okay.
polyps, you have fleshy growth in the lining of the womb. You could have painful periods and heavy periods at the same time. And sometimes painful period may just not have very clear cut causes, like what we call primary dysmenorrhea. For instance, you don't have any cause to really associate it with
Yeah.
or link it with. So these are all period pains that are not endometriosis. But endometriosis is a major cause of period pain.
Interesting.
Major cause of period pain. It also causes mid-cycle pain because it is a condition that responds to the reproductive hormones of a woman.
Okay.
And the reproductive hormones of a woman, rises and drops
Yeah.
depending on the phase of the cycle. And the endometriosis, metrotic deposit respond to those hormones. And at those times, you could have pain. And then the pain is usually more during periods. But you asked, what is
What it is,
endometriosis? Now, the female reproductive organ, the uterus, has different layers. You have the outer layer, which is the outer covering of the womb.
Okay.
The anatomists call it the serosa. Then you have the muscle layer of the womb, which is called the myometrium.
Okay.
That's the middle layer.
Yeah.
Then you have the innermost layer of the womb, which is where menses falls out from, or breaks out from, or flows from.
Flow.
You know, and that is where implantation happens.
Okay.
It is fluffy, like hairs, like has glandular tissues, and all of that. The innermost layers.
Yeah.
So when this innermost layer of the uterus translocates itself to other parts outside the uterine cavity, maybe you find it on the ovaries, on the fallopian tubes,
Okay.
on the support structure of the womb, like this, like the uterosacral ligaments support the womb.
Yeah.
Sometimes on the rectum.
Yeah.
I
Wow.
mean, intestines. Sometimes in the liver, in the lungs,
That far.
even the brain.
Oh wow.
This is what we call endometriosis. They are ectopic. Ectopic endometrial tissues. So when these endometrial tissues are found outside the uterus, outside the womb, a woman is said to have endometriosis.
Okay.
Yes, so that's what endometriosis is.
Interesting.
Having this uterine lining or uterine lining like tissues outside the uterine cavity,
Yeah.
then you have endometriosis.
Okay.
So that's
Oh,
endometriosis.
that's interesting.
For a layman.
I mean, for how much it travels, like, how do you even get from there all the way up here? That's
Oh yeah,
really
that's why the
insane.
theory for endometriosis is still like mystical.
Yeah.
You know, the womb is down here in the pelvic cavity, and then you have a tissue that looks like it's emanated from the womb in the brain
Yeah.
or in the lungs
Yeah.
or in the intestine, on the intestine. I just wonder how it gets there. So different theories tries to explain how it
How it
gets
gets
there.
there.
Some of the theories make sense and some do not make sense. But genetics, it's one common thing that tend to tie all the theories together.
Yeah. Okay, so we spoke about some symptoms. I mean, you said period pain is one of the most, should I say, dominant
Yeah.
symptoms in endometriosis. But what other things can a woman with endometriosis experience?
Okay. Let's talk about this period pain
Yeah.
first. Often when a lady walks into the gynae consulting room and talks about having pain during menses,
Yeah.
the first thing we think about is endometriosis because it's common and it happens to young girls, mid-aged girls, and then big girls. So long as you're in the reproductive age and
Anyone
you started
really?
having menses, you could have endometriosis.
Okay.
So the major symptom is pain. That's what's common amongst so many people having endometriosis. It's a kind of pain that comes at menses, during menses.
Yeah.
You know, so that's the main symptom. But other symptoms now depends on where the endometriosis, endometriotic tissues
Yeah.
are located.
Okay.
One, you could have endometriotic tissues on the ovaries. They grow into what we call cysts. And then you hear the gynecologist say chocolate cyst.
Yeah.
And that's because the content of the cyst looks like hot chocolate, like chocolate. That's that brown stuff, right?
Yeah. Yeah.
Yeah, it looks like chocolate,
Wow.
very thick and all of that. So, and that causes a depletion of the eggs of the woman. Oh yeah, once it gets to the ovaries, it affects reproduction. So it comes with some form of infertility. Other symptoms of endometriosis could be blood discharge from some other parts of the body.
Okay.
Yes, you have quite a number of ladies having a discharge of blood from the belly button.
Wow.
Yes, you see the belly button looks black and hard, and they'll tell you classically that during menses, they observe blood flow from the belly button. That is endometriosis already, advanced endometriosis. Yeah, and then after menses, it stops. You know, but during menses, the blood flows
Things from
again.
yeah.
So now you have endometriosis around the umbilicus. So this is abdominal endometriosis, for instance, because it means it's possibly affecting all the structures around there.
Yeah.
Now you have endometriosis in the rectum, for instance, and a woman can be passing blood during stooling, during her menses.
Oh.
Bloody stools
Yeah.
during
Yeah.
menses. Some have endometriosis in the lungs, and they have chest symptoms. They cough and they cough out blood.
So,
You know, hemoptysis. We call it hemoptysis when you cough and there's some blood in it. And then some have it in the brain. Few people, very it's a strange presentation having it in the brain,
Yeah.
and
Very
then it
strange.
comes like a space occupying lesion, because during menses the symptoms will come in the brain. You could have a woman convulsing
Wow.
during menses. You know, wonder what connects menstrual flow with
To
convulsion.
convulsions, I mean,
So it gets to the brain. So, and so this is getting outside the realm of
of
the
human reproduction.
gynecologists.
Yeah.
Now it's in the neurosurgeons domain. Then the one in the chest is in the cardiothoracic surgeon's domain.
Domain, yeah.
That he will need to treat it alongside the gynecologist.
Of course.
So these are different ways. Then, so it gives chest symptoms. You have brain symptoms. You have intestinal symptoms.
Yeah.
But one crazy thing it causes is the adhesions.
Okay.
When it's in the pelvic cavity, for instance, affecting the support ligament, support structure of the uterus,
Yeah.
the fallopian tubes, then the structures get glued together,
Oh, okay.
so that the anatomy of the pelvic is distorted. Intestines are adhered to the uterus, adhered to the fallopian tubes, adhered to the ovaries,
Yeah.
Just like that. So the anatomy is just damaged. So it now becomes difficult to get pregnant.
Yeah.
Yes. So women with endometriosis could get pregnant. Sometimes easily.
Okay.
But when it gets to this advanced stage, pregnancy becomes very difficult for several reasons.
Yeah.
So these are some of the symptoms. But pain is usually very central
Yeah.
to a good number of them. But it's good to mention that it's not all painful menses. That is endometriosis.
Endometriosis.
Yeah.
Okay. Well, I mean, like I said in the beginning, I thought I also had endometriosis at some point when I was in school, because I would always have really painful periods. Like whenever my period comes around, I'm sick, I'm throwing up, I'm not able to tolerate anything. But like you said, yes, it just is not the same thing, although it can be something. And I had it checked out. So if you're struggling with that, it's a symptom, yes, but you should have it checked out. You should go to your hospital, your gynecologist, your fertility specialist, whoever it is. And you spoke about how it's some advanced endometriosis that could cause adhesion. So that makes me think that there might be some endometriosis that is not quite advanced.
Yeah.
Yeah.
Sometimes, endometriosis may, there are different grades of
Okay.
endometriosis.
Okay.
So the earlier grades are not that advanced to cause those crazy adhesions.
Yeah.
But the advanced grade of endometriosis or stages of endometriosis could be associated with a lot of pelvic adhesions, to the point that you could have a frozen pelvis that you can't differentiate the structures because they've been glued badly together.
Yeah.
So that's advanced endometriosis, and then it's difficult to care for.
And then you also mentioned how it affects fertility. I don't know if you could go into it a little bit more, because I mean that's our topic after all. And you've spoken about the effect it has on the ovaries, on the lining of the uterus. So how does it actually further
So now,
affect fertility?
when endometriotic deposits are found on the ovaries, they grow into cysts sometimes,
Yeah.
and then these cysts stay on the ovaries, a part of the ovaries, and then these cysts produce chemicals, and the chemicals affect the quality of the female eggs, affect the movement of sperms, affect the movements of the eggs.
Yeah.
And so you see infertility just happen easily. But much more than that, this recurring, because these cysts don't just go away.
Okay.
Even if you do the surgeries you have to do, it improves on the symptoms when you cut out or burn out the cysts by laparoscopic surgery or some form of surgeries, But then endometriosis may still come again, because it's practically like a situation that lasts the entire reproductive lifespan of a woman. So that the only thing that stops it is when you're out of reproductive function.
Oh wow.
Or there is a condition that takes you out of reproductive function, which is menopause, or if you get pregnant, it stems it for a while, at least the entire period of pregnancy. So the cysts keep growing on the ovaries, and they damage the antral follicles of the ovaries. And then anything that affects the antral follicle, that's a reserve of eggs in the ovary, technically takes out the capacity to achieve pregnancy.
Yeah.
You see that's infertility. Then, depending on the extent of the deposits, they cause adhesions, and these adhesions alters the anatomy of the fallopian tube sometimes. So it makes the fallopian tubes to either accumulate fluid or blood, and then they don't flow out or flow in anywhere, and so it affects the line of transport or movement of eggs and sperms for fertilization. So that way, pregnancy doesn't just happen spontaneously,
Exactly.
So that's one major way that this happens. It takes out the ovarian reserve, it causes blockage of the fallopian tubes, or distorts the anatomy and physiological function of the fallopian tubes. Sometimes it takes the fallopian tubes far away from where the ovaries are, so they are not in alignment to just allow eggs and sperms to flow freely, meet freely, and become pregnancy. So that's one way it does. And for people that have endometriosis, their ovarian reserve usually depletes faster, yes, than those without endometriosis.
Yeah.
And a good number of time, even when you stimulate them for, let's say, you're doing an IVF, you stimulate them to produce eggs before retrieval. The rate of production of egg is usually poor as compared to the counterparts, the female counterparts without endometriosis. So you could be giving a woman medications to produce eggs, and you're growing more endometriotic cysts.
Oh wow.
Yeah, we've seen that quite a number of times. Yes, and what in advanced society, what very prospective gynecologists do is that when a woman has endometriosis, they try to treat her and get her eggs first,
Yeah.
and save the eggs.
Okay.
Then before going to treat her condition, before coming to try to make her pregnant. So
That's
endometriosis is quite a menace.
Yeah.
And of most of the gynecological conditions, I think it may either be the first or second that I hate to hear about.
Well, now I want to know which one comes after that. But yes, that sounds very intense, I would say. And since it has symptoms that well, the pain, for example, could be similar to something else, like you mentioned. I think up to 5 other things that could cause such a thing. So, what way would you say is the most reliable to diagnose this, especially with women that have been going through some infertility issues or fertility issues in general?
The commonest way to diagnose,
Yes.
you start by suspecting it as a gynecologist. A young lady in the reproductive age come with pain. You look out for possible causes of the pain, and one of the first things we think about is endometriosis. If you do a scan, for instance, you could see signs, cystic lesions that with the typical description of what looks like endometriosis on ultrasound scan. Multiple of them sometimes, with their chocolate contents. You could see that on ultrasound scan.
Oh, wow.
But the most direct way to make a diagnosis is to do what we call a laparoscopy.
Okay.
Yeah, in laparoscopy, for instance, you make a hole. It's just like a keyhole surgery. You make a hole on the abdomen, one or two punctures on the abdomen, and introduce cameras and other instruments to manipulate the pelvic anatomy. The uterus, the fallopian tubes, and then you could see in real life. Under HD high definition cameras or 4K cameras, the deposits and where these deposits are. So with this kind of intervention, you're able to make the diagnosis of endometriosis because you see the deposits of those endometrial tissues in the pelvic and abdominal cavity, if they are there, and you see where they are located. You see the extent, you see the grades, and then you'll be able to make a forecast how the life of this young lady or advanced age woman is going to be like. So that's laparoscopy now to make diagnosis of endometriosis. But sometimes people make this diagnosis just accidentally. You go in for a fibroid surgery, for instance, and you now see that this woman has had endometriosis all the while alongside fibroid. But in 2024, yes, I was with a group of reproductive specialists in Colorado, US, who were trying to simplify the diagnosis of endometriosis. Not just necessarily simplifying it, but be able to predict using some blood markers which woman will likely have endometriosis, so we could take steps in safeguarding her reproductive potential before it even strikes her and goes far. So we're looking at possibility of taking a blood sample, and looking at the blood sample, then we'll be able to tell that this is likely going to be endometriosis in the future. It's a prospective test. So we're working on that. We're yet to come out with something significant. So we are supposed to represent a unit in Africa. A unit in Africa looking at prevention, or rather the forecasting endometriosis. So I guess that would be a very advanced one, so that women with and who will have endometriosis can think of what to do with their eggs before it starts. Before it's affecting them.
Well, I mean, you mentioned earlier that even with endometriosis, a woman could still conceive. So with all these markers that can affect fertility, let me think of the more positive side of it. Is it when endometriosis of a certain grade, or at what point will a woman with endometriosis not even have to worry too much, I would say, or can they actually just conceive naturally?
No, now it's very tricky to answer this question. Okay, you could have women with even advanced grade endometriosis getting pregnant. You're just getting pregnant a little bit easier than you anticipate. So it's not necessarily the extent of it. So pregnancy just happens mysteriously sometimes, but then pregnancy generally it's more difficult for people with endometriosis than those without endometriosis. And then you could have an early grade of endometriosis, but the endometriosis is sitting on a very bad place, and then it's affecting connection between eggs and sperms, even when it is not the advanced stages you're dealing with. But the really advanced stage is already affecting the eggs, the ovaries. It's usually poor prognosis. And sometimes when we see young ladies, even at IVF, we tell them, yeah, you may be 30, but chances that you have good eggs from this treatment is very, very slim. Wow. Very, very slim.
Can you imagine having to, think you're still young and you're getting that prognosis? Probably.
The past 2 days, I've seen quite a few ladies with endometriosis. Yeah, they're between 29 and 30 and 31. And their egg reserve is nothing to write home about. Some of them are actually going to have IVF with egg donation. Can you imagine age of 29, 30, 31, thinking of egg donation because of endometriosis? It's that bad. A good number of times these ladies want to try, try to see what will happen. And
I mean, but already that prognosis is not very
prognosis
good.
is not very great.
Very good. So at what point would you say a woman or a couple would consider IVF or any other sort of assisted reproductive technology, especially with endometriosis?
Yeah, if pregnancy is delayed, beyond the comfort of what they accept to be normal for them, and endometriosis is diagnosed, it's good to go for the fastest means of getting pregnant, because endometriosis progresses. So you may think that you want to wait and see, and the endometriosis continues, because it's a progressive condition. It doesn't stop. And even if you give medications to stop it, the same medication to stem its progress prevents the woman from ovulating.
Wow.
Yes. And so you're achieving nothing with respect to fertility. You understand? So it's just a tough situation with endometriosis. So there is no time. I think it should be individualized, and every woman should be evaluated based on her own case. And I think the gynecologist should be more aggressive, making a woman with endometriosis pregnant and allowing her to watch and wait. I don't like waiting. Yeah, because you could just wait
and it could
just get worse.
And worse.
Yes, get worse. So do what you have to do quickly. Yeah, because endometriosis is crazy.
Okay. Well, I mean, already in the talk of IVF and other assisted reproductive technologies, spoken about how, these medications can alter even the things that you're trying to look forward to, like you said, ovulation just now. So, is there any specific treatment that would actually make it better or work better for women with endometriosis?
Yes, the best form of treatment for endometriosis is to do a laparoscopic surgery
Okay.
and to bond the tissues with the to bond the endometriotic tissues using the let me use the word electrical gadgets.
Okay.
Some of the instruments at laparoscopy are energy controlled gadgets.
Yeah.
So you can use that to bond the deposits. That way you improve the quality of life and you prevent the progression. Then you take out the cyst and bond the cyst cavity. You just peel off the cysts and take them out. So you have reduced the progression of those diseases. So laparoscopic surgery, it's one very vital way of addressing endometriosis. But then it may be very difficult too because endometriosis could be affecting the intestines, could be affecting the liver and all of that.
Yeah.
And if you have those extent, then this is getting beyond the realm of the gynecologist. You need to go as a gynecologist and and the general surgeon sometimes,
Yeah.
because once the intestines are involved in endometriosis, you need an intestinal surgeon
Wow.
to assist with that kind of surgeries. So the surgical intervention is for a woman looking at fertility.
Yes.
Surgical intervention, I mean, laparoscopic surgeries are the best form of treatment. All other form of of care would prevent her from ovulating. Usually the medications are preventive because once the woman is producing estrogen and is having ovulatory cycles, endometriosis continues to make progress. So one of the ways to treat it is to stop ovulation.
And then
And if you stop
discarding
ovulation, there's no
fertility.
problem. You're going to
Yeah.
make progress with pregnancies.
Exactly.
So yeah, that's just one. That's
Oh,
yeah,
okay. Yeah, well,
it's a
I can
surgery.
imagine. And like I said, it seems like there's no real win-win. You can't try to treat it with just normal medical options and then
Exactly.
also preserve fertility at the same time.
Yeah.
So the best thing out there is just that laparoscopic surgery.
Yeah.
And then I have a
Laparoscopic
question
surgery.
before we get towards the end of this. For an endometriotic cyst, even after the surgery, is it possible for it to grow back or to come
Yes,
back?
grow
Yeah.
back again.
Oh wow.
One peculiarity is endometriosis is that it doesn't go. You could just help improve the quality of life of the woman at that point in time.
Wow.
And if she has finished her reproductive activities, then you
Yeah.
keep suppressing them with medications. That way, she does not ovulate. You're inducing kind of menopausal states in her, you know, and then no ovulation happens. But after taking a cyst out or cysts out, it's not surprising you could have some of the endometriotic deposits producing cysts around the ovaries or pelvic cavity. So it's quite interesting.
It is.
It is interesting.
It's interesting. It's been interesting from the start, but it's also quite grim. I mean,
Yeah, it's not an interesting gynecological condition.
no wonder it's
It is not interesting gynecological
top one
conditions.
for the things you hate.
And as a gynecologist, one thing that bothers me is how endometriosis uh, is, I mean, develops outside the normal theories of what we know cause endometriosis.
Yeah.
The easy theory is they say the backflow of menses, and the backflow of menses goes with some deposit of endometrial tissue. So they so if you lie with endometrial tissues, so lining of the womb is responding of the womb wherever they are in the brain, in the lungs, in the intestine, liver, and everywhere.
Wherever.
So and ectopic endometrial tissue that form from human development. So you can find it. But then you see sometimes gynecologists go to do some surgeries. Like you're doing a cesarean section, for instance, and some endometrial tissues are translocated from the uterine cavity outside the uterine cavity.
Wow.
Sometimes they go into the wall of the uterus, depending on how the stitches is done. And then if the tissues are not native to that to that part of the uterus, they grow as glands. And then adenomyosis develop, or sometimes it grows outside the uterus itself as ectopic as endometriosis.
Yeah.
Adenomyosis is the same as endometriosis, but just that it's occurring on the uterus itself.
Okay.
So those are some of those things. And sometimes those endometrial tissues, when you're doing a C-section or even a fibroid surgery, that endometrium is breached, could just be deposited on the skin.
What?
Yes, skin, maybe along the line of incision.
Yeah.
In an open surgery. And then you finish your surgery, a beautiful surgery, and the woman keeps having this pain on the skin along the line of your cut.
That would be so confusing.
And then this pain will come when she's menstruating. She feels pain along the line of surgery.
Yeah.
That's endometriosis.
Oh.
You understand? And when menses is over, it stops. Then when menses is coming, the pain comes again.
I should probably just think, oh, it's just her scar.
Exactly.
Acting up. It's just the
so
surgery.
Handling of tissues during surgery is also very important. Yeah, this happens. We call it iatrogenic or accidental, not intentional. But it happens. It just happens. So it's good to handle these tissues with care. With care.
That sounds very important.
Handle the tissues with care.
Well, I know this is very, like I said, it's quite grim, but if I could end on something I want to consider a lighter note, what advice I would say do you have as a gynecologist and all the experience that you've seen for women with endometriosis for women who want to have children in the future or want to preserve their fertility? What advice would you give them?
Okay, let's assume I'm a woman. I'm a genetic male. But let's assume I'm a woman. And I'm diagnosed with endometriosis, and I'm yet to have babies, and I intend to have babies. I think the first thing I'm going to do is how to preserve my eggs. So I'm going to meet a reproductive gynecologist and talk about the prospect of freezing my eggs. Because endometriosis will make progress, and you don't know how soon you're going to need to have babies. So I don't know how long you're going to be with endometriosis before you want to have babies. You may just need to have babies when endometriosis have taken over the entire ovaries and have damaged antral follicles and ovarian tissues. So it's good to safeguard the eggs, to freeze the egg. That's the best advice I can give to any woman. And then in addition to taking care of the symptoms of endometriosis, which include seeing a gynecologist and adhering to gynecological advices with respect to care for endometriosis, which could be surgical or medical. So that's just the advice I will give. And as I told you earlier, with the team we had meetings with in Colorado, in 2024. Our intention at the meeting is to be able to forecast or predict a woman that would have endometriosis. So we could advise her or advise that group of people on how to go about their reproductive life instead of having to wait until the disease manifests itself, and then you would have to do laparoscopy and all of that. And then at that point, you're dealing with advanced disease condition often.
Exactly. Well,
so that would be my best advice. That would be my best advice.
Well, I mean, if I was struggling with endometriosis, it would be nice to know that there's still something I can do about it. There's still,
and these endometriosis guys usually a nightmare to those of us in the field of. Sorry, I think yes, ladies.
No, you're good.
Endometriosis. The nightmare to us in reproductive medicine because more often than not, it's very difficult to care for this group of people for one reasons or the other. Just very difficult. Either they are going to have surgery, preserve eggs, then come back later, take the eggs over again, or you're just having no eggs, or you stimulate and they are producing chocolate seeds instead of follicular or follicles with eggs. Endometriosis is just crazy thing.
Just one thing or another.
It's crazy. Endometriosis. It's a mad one.
Actually, it does sound like
a mad one.
Well, thank you for joining us here once again. We really do.
On the lighter note, we have this group of gynecologists during my days in residency.
Please, the lighter note is very much appreciated. Go ahead.
during our residency days, and
Yeah.
and then they want to date a lady, and say, you can do you have menstrual pain. Hold on.
And
And then
you're
when she has
already
menstrual pain, they say, maybe endometriosis
you're
here.
already diagnosing before you go for you're like, oh
It's just like the psychiatrists, for instance.
yeah.
The psychiatrists see all of us as mad people. I mean, as having some form of psychiatric illness.
Yeah.
I remember doing psychiatry in medical school, and when I talk with somebody, I see some madness in the
Okay.
person.
Oh my days. I can
So the gynecologists think that way.
yeah.
Think that way, and in some other areas,
Hmm.
yeah.
A lot of other
They
areas,
just
I'm sure.
I hear gynecologists say, "Kai, this lady, I think the ovarian reserve is quite low
Oh
here."
my god.
Welcome to the
Well, it
world
must
of
make it
gynecologists.
quite difficult for you to get with someone.
But you can't help it. That is the
Yeah.
training.
I mean,
And it's difficult. It's just like a military guy, for instance, or
mhm.
somebody who is into counter-terrorism.
Yeah.
If he's entering into a building, he's imagining whether there is a sniper somewhere, or whether there is somebody trying to plant a bomb somewhere and trying
Exit
to plot his way in
strategies,
and out
in
the
out.
property.
Yeah.
So you can't help. If an architect entered this building, for instance, the first thing is, look, who designed this?
Mm-hmm.
Is this design, is it modern, is it good, is it accurate, why is
Yeah.
this? So that's the life of a gynecologist.
I mean, knowledge is power, but it's also quite.
And if you see a lady that is not too tall, Kenneth a good
Yeah, that's just you reprimanding yourself.
now, this happened in medical school, when we're doing a labor and all the forces of labor, I mean labor, delivery labor.
Yeah.
They tell us that the height. I mean, for Africa, though, not China, not India, and all,
Yeah.
because you have quite a
lower
lower
range
range of
than
short
average height,
average
yeah.
height is lower, and they have good deliveries, but it's a pelvic anatomy configuration.
Yeah.
But in Africa, we are in Nigeria like 1.5, and then you're trying to go out with Lydia, and she's 1.5 and below, and your friend will say, "I can." You sure so you to make the right move, so. So the gynecological life is an interesting life.
It is actually. I mean,
we are happy the way we are,
Okay, good. As long as you're happy. As long as your partners are happy as well.
We are happy.
Oh well, it's really good to end on a lighter note.
Oh, yeah.
But just to remind everyone, we spoke about endometriosis and fertility. And as grim as it could have sounded through this, I just hope you know that there is something you can do about it. And if you're confused and you're dealing with some of these symptoms that you just never understood why you were dealing with this, you might want to see your doctor about that. And for your fertility options or treatments or chances, you would want to see your gynecologist or fertility specialist. And this is a shameless plug because at Alps Hospital, you have both of those things. I mean, look at Dr. Ken over here. But we do have a lot of other professionals that can help you go through this process. So thank you once again for joining us. It's always lovely to have you on here. Please stick around with us every Wednesday and Friday by 3 p.m. We go live on every social media platform: Facebook, TikTok, Instagram, YouTube, wherever it is. We go live. Turn on your post notifications so you do not forget. And even if you do, it will remind you. Okay, I remain Joanna Damina, your host, and I will see you next time. Bye.